Look, let me guess. You're coding an OB chart. Everything looks fine. Routine prenatal visit, nothing complicated. And then, one small sentence stops you cold. Patient reports occasional alcohol use. And suddenly, you freeze. You're thinking, do I code this? Do I ignore it? Is this even relevant? What if I cause a denial? So you do what most coders do. You scroll past it and hope it doesn't matter. If that sounds familiar, this video is for you. Because that exact moment is where most OB coding errors begin.
This is Coding Doctor, and I spend way too much time thinking about ICD-10's Chapter 15. If you're someone who also finds difficulties in coding OB cases, make sure to hit the subscribe button and give this video a thumbs up if this helps you out. Today, we're covering one of the most uncomfortable and most misunderstood areas of obstetric coding: alcohol use, tobacco use, drug use, poisoning, and abuse during pregnancy. Not because these cases are rare, but because coders don't like dealing with them.
Here's the thing. This isn't just about coding rules. It's about psychology. These topics trigger fear. Fear of overcoding, fear of audits, fear of getting the provider in trouble. So the brain does something sneaky. It says, if I don't code it, I can't be wrong. That mindset feels safe, but it's exactly how errors slip through. Let's ground this in real numbers. Public health data consistently shows about 1 in 9 pregnant patients report alcohol use. Roughly 7 to 10% report tobacco use. More than 5% report drug misuse. And abuse during pregnancy affects nearly 1 in 6 women. So if you think, I don't see this often, you do. It's just quietly documented.
Section A. Substance use in pregnancy. Alcohol use. 099.31. Here's what most people don't realize. You do not need complications. You do not need fetal harm. You do not need withdrawal. You only need documentation of alcohol use.
Real-life scenario.
Prenatal note says, patient drinks wine socially on weekends. That's it. Most coders skip it, but ICD-10 doesn't. Correct coding. Assign 099.31. Alcohol use complicating pregnancy. And if the provider documents abuse, dependence, or intoxication, add a secondary F10 code. Why? Because alcohol use automatically affects pregnancy risk and management, even if no one says it out loud.
Tobacco use. 099.33. Now, let's talk about smoking. Cigarettes, chewing tobacco, vaping, they all count. Real-life scenario. OB intake note. Smokes 5 cigarettes per day. Counseled to quit. Coder thinks this is common. But common does not mean optional. Correct coding. Assign 099.33. Smoking complicating pregnancy. Then add F17 to identify nicotine dependence. Here's what most people don't realize. The moment tobacco use is documented, pregnancy management is considered affected. That's why Chapter 15 takes priority.
This is where it gets really interesting. Because drug use does not mean illegal drugs only. It includes prescription misuse, taking someone else's medication, non-compliance that causes harm. Real-life scenario. Chart note says, patient using partner's pain medication for back pain. This isn't a judgment call. This is a coding rule. Correct coding. Assign 099.32. Drug use complicating pregnancy. Then add secondary codes from
F11 through F16, F18 or F19. Those codes explain the substance and its effects.
Section B. Poisoning and adverse effects. Now you might be thinking, okay, but poisoning is different. Yes and no. Real-life scenario. A pregnant patient presents with accidental overdose, toxic exposure, adverse medication reaction. Here's where coders make a critical mistake. They jump straight to the poisoning code. Correct sequencing. First, 09A.2, injury or poisoning complicating pregnancy. Then, the poisoning or adverse effect code. Then the condition caused by it. ICD-10 wants to know why pregnancy matters first. Miss that, and the claim is vulnerable.
Section C. Abuse in a pregnant patient. This section makes coders uncomfortable, and that's exactly why it matters. Real-life scenario. Documentation states, patient reports domestic violence, bruising noted. Some coders hesitate. They think, this feels sensitive. It is. But sensitivity does not cancel sequencing rules. Correct approach. Assign the abuse code first. 09A.3, physical abuse. 09A.4, sexual abuse. 09A.5, psychological abuse. Then add injury and perpetrator codes if documented. These codes affect more than reimbursement. They affect patient safety. Here's the truth. Coders don't undercode because they're careless. They undercode because they want to stay invisible. They confuse discomfort with inaccuracy. They mistake silence for safety. But accurate coding is not about comfort. It's about reflecting documentation faithfully.
Here's what you can do, starting today. Step 1. When you see substance use, injury, or abuse, pause. Step 2. Ask one question. Does ICD-10 assume this affects pregnancy? In these cases, the answer is yes. Step 3. Assign the Chapter 15 code first. Step 4. Add secondary codes for details and manifestations. That's it.
Obstetric coding isn't hard because it's complicated. It's hard because it forces you to make decisions. If you can code this section confidently, you're no longer just following rules. You're thinking like a professional. If this clarified something you've been avoiding, hit the thumbs up. Subscribe for more real-world OB coding clarity. And comment below what obstetric topic still trips you up. I'll see you in the next one.